Coming up in this episode. Now, reflexes. What are my tips here? Big tendon hammer. It is really, really, really important, particularly for a obese patient when examining the patella joint. So if you've got someone with a BMI of 45 and you're trying to strike their patella with a tiny little reflex hammer, you're going to have a bad time. It is so much more helpful to have a nice big juicy tendon hammer with a nice big juicy head to it so that you can get some weight behind it and apply a sufficient strike to elicit a sufficient knee reflex. Hello and welcome to the next installment of Risfeld Neurology Education, a not-for-profit, free open access project with a philosophical touch exploring all areas of clinical neurology, meant for medical students through to neurologists and any health professional involved in the care of patients with neurological conditions. Today's episode is focusing on the theory of the lower limb neurological examination with associated pearls and pitfalls. And it's another episode in the Clinical Method series. And I'm your host, Tom Risfeld, a neurologist, epileptologist, and neurophysiologist and neuromuscular specialist, and also a physician, philosopher, and bioethicist. Before we get into it, a quick legal disclaimer. The content of this episode is for educational purposes only. So, the overview of the episode today, it's a follow-up to the previous episode on the examination of the upper limbs. And just like that episode, this is going to be going over my routine assessment of the neurologic assessment of the lower limbs for every neurologic patient that I see. There are some components which are not routinely performed, which are performed in specific clinical circumstances, which will be addressed in detail in other episodes evaluating those contexts. But this is the routine assessment, the core of my assessment that I do for every neurologic patient, and it addresses 95 to 98% of what you need to know in terms of all of the total material anyway. So the overview is we'll be talking about positioning and exposure, which is going to be with the patient lying in bed, then inspection and sometimes palpation, tone, power, reflexes, sensation, coordination, stance, and gait in detail. In regards to components of the lower limb neurologic examination, which is also relevant but is more in the context of other contexts which come up in other episodes, as I just mentioned, there are some other forms of extrapyramidal testing, such as retropulsion testing, and there are some other components of neuromuscular testing. So, for example, fatigability testing, if you're considering a disorder of neuromuscular junction transmission, such as myasthenia gravis, or some specific aspects of power assessment, for example, hip abduction and adduction, ankle inversion and eversion, particularly inversion for distinguishing an L5 radiculopathy from a common or a deep perineal or fibular lesion, given that a weak inversion is consistent with an L5 radiculopathy, but not with a common or deep perineal lesion. And also testing great toe dorsiflexion to assess the extensor hallucis longus muscle. So they're just some examples of components of the lower limb neurologic examination which are important in some contexts, in neuromuscular contexts, but I don't routinely examine EHL, for example, or hip AB or adduction or retropulsion testing if I'm seeing a standard neurology patient that doesn't fall into that specific context. So if it's someone with seizures who I'm seeing in an epilepsy clinic, or someone with migraines who I'm seeing in a headache clinic, I don't test for EHL, for example. So let's get into the detail. So, inspection and palpation. Firstly, you need to have adequate exposure. Ideally, this should be from the hips down, although that can be a bit invasive for some patients, and it may be reasonable to compromise depending on the clinical context. Like, you might not need to get a patient who you're seeing in an epilepsy clinic to completely take their pants off just to examine their lower limbs, and it may be reasonable to compromise depending on the clinical context. But in an examination setting in particular, or if you're really concerned about a neuromuscular process and you really want to have a good look for wasting and fasciculations proximally and around the gluteal muscles, then you do need to adequately expose the patient from the hips down. They can, of course, still wear their underwear, and then if you need to have a good look at the gluteal muscles, you can just pull back a little bit of the underwear briefly to check the gluteal muscles, for example. So, what are we actually looking for? Well, like in the upper limbs, we're looking for wasting, and we're focusing on what is the distribution of the wasting. Is it unilateral or bilateral? Is it affecting predominantly the anterior or the posterior compartments? Is it just one muscle? Is it a large distribution of muscles? Is there a distal to proximal gradient, etc.? And then we're looking for fasciculations. And again, you need to look for a sufficient length of time at a sufficient range of different muscles. So it's not good enough just to have a glancing look at the legs for 2 or 3 or 5 seconds. You have to have a really good look because sometimes fasciculations are not that frequent. And we know that in the lab, when we're doing needle EMG, electromyography, for example, and we're looking for fasciculations if we're perhaps doing a MND screen, we really have to be patient and you have to wait for the fasciculation or the neurophysiological equivalent of a fasciculation to come on. And sometimes you need to leave the needle in the muscle for a minute and there may be really quite infrequent fasciculations. So you have to have a good look and you have to be patient. So at a minimum, you should be looking for 15 to 30 seconds per muscle. And if you're really concerned about MND or you're really interested in excluding fasciculations for some other reason, you may need to look for much longer than that. And you need to look at both sides, at proximal and distal muscles. You have to have a good look for fasciculations. Additionally, if you're not seeing any, then it can be helpful to try gently flicking the muscle to precipitate them. So just doing a gentle, not completely gentle, but reasonably gentle flick to the muscle to try and bring out the fasciculations. In the lower limbs, you're also looking for obvious musculoskeletal deformities. So, for instance, a Charcot foot with pes planus. And in that instance, you should be thinking of conditions such as diabetic peripheral neuropathy or pes cavus, so a high arch foot. And this is a little bit confusing because a high arch foot, pes cavus, can also be a neuropathic foot, which can be seen in the context of Charcot-Marie-Tooth CMT disease, for example. So it seems that Charcot, the famous French neurologist, was far too prolific for his own good and he put his name to too many different conditions and it's a bit confusing. So just to reiterate, Charcot's foot is seen in pes planus, so flat-footed conditions with hammer toes, and that is suggestive of, say, a diabetic peripheral neuropathy, for example, or conversely, pes cavus, or a high arch foot, can also be present in a neuropathic foot, which can also be seen in some other neuropathic conditions such as CMT disease. Now, of course, you would also take note of any involuntary hyperkinetic movements if you were to see them, for instance, tremor, although in an extrapyramidal context, for example, in a Parkinson's disease context, we know that the upper limbs are much more involved than the lower limbs typically. Palpation is really mainly in a neuromuscular context, so palpating for muscle swelling or tenderness, especially in the context of some metabolic myopathies. And of course, taking note of any obvious cutaneous lesions. So if there's any atrophic hair or skin changes or ulcers, then that might be consistent with underlying vascular disease, which could be concurrent with an etiology for diabetes and a diabetic neuropathy, for instance. So take note of any of those cutaneous changes. Moving on to tone. So how do I do this? So I examine hip and knee flexion and extension and ankle dorsiflexion and plantar flexion. And just like in the upper limbs, you need to be assessing a range of movements, so through the whole range of movement of the joint, and you need to be going through a range of velocities as well. And we spoke about this in the previous episode, so I won't spend quite as much time on it. But the reason that we do a range of velocities is to distinguish if the patient has increased tone, so hyper-PER whether it's in a velocity-dependent hypertonia, also known as clasp knife hypertonia or spasticity, or conversely, whether it is velocity independent, and that's like a lead pipe rigidity. We would describe that as where the stiffness is present the whole way through the range of movement, irrespective of the velocity that you're moving the joint at. And that's consistent with an extrapyramidal pattern of hypertonia. And if there does happen to be superimposed tremor in the lower limbs, then that can result in cogwheeling, albeit, again, the distinction between both of these is probably more clinically relevant in the upper limbs, given that Parkinsonian syndromes have a predilection for affecting the upper limbs more so than the lower limbs, especially in the earlier stages of the diseases. And similarly, as for the upper limbs, hypotonia, P-O-tonia, is a little bit trickier than hypertonia because it's not always abnormal, especially in young, otherwise healthy patients. So you do, again, have to examine this and then interpret this with caution and in the context of all the other symptoms and signs. So if the patient is completely asymptomatic from a neuromuscular perspective and they don't have any abnormal signs apart from isolated hypotonia, then it's probably within normal limits for that patient and it's probably insignificant. But if they have symptoms consistent with a neuromuscular condition or a central condition causing weakness or sensory loss, and if they have hypotonia in combination with hyporeflexia and weakness, then that's clearly a significant finding. And of course, we know that hypotonia is consistent with lower motor neuron lesion pathology, again, with the exception of the acute phase of an upper motor neuron lesion, where you can get this initial hypotonia and also hyporeflexia, and then with time, it then evolves. The actual time course can vary between patients, so it can be just an hour or a very short period of time, or it can be up to a week or two, and it's quite variable. One other trick in terms of examining tone is you may have seen physicians or other doctors also assess tone by briskly elevating the thigh proximal to the knee joint. And it took me a while to realize exactly what you're looking for here. So you do that, so you put both of your hands beneath the thigh muscle proximal to the knee and then quickly jerk it upwards. And what you're doing is you're actually looking at the foot when you do this and you're seeing if the foot remains on the bed or not. So if there is not hypertonia present, so there's no increased tone, then the foot should remain on the bed. So the hip will be flexed because you've caused that to happen. And so what should happen is the gravity should still cause the foot to stay on the bed, but it will just be dragged back towards the patient's bottom. Conversely, if there's increased tone and so the knee joint stays stuck in the same angle that it was before you quickly passively flex the hip, that flexion then causes the foot to be raised up into the air, so the foot will leave the bed and get raised up into the air, and that is consistent with increased tone. So that's just something to understand there. Next is power. So what muscles or what joint movements do I test routinely for all comers? So I test hip flexion and extension, knee flexion and extension, and ankle flexion and extension. There's a few tips that I can give here. So firstly, with hip flexion and extension, it's important to realize that the position of the knee can actually affect the power that they appear to have with hip flexion. So it can be helpful to ask the patient to flex the knee a little bit just before you actually test the hip flexion. And you might be surprised to see that the hip flexion is almost always quite a lot stronger when you do that. So if the patient's knee is completely extended and then you test hip flexion, it might feel a little bit weak. But then if they bend the knee a bit and then flex the hip, it suddenly feels really strong. So it's good to ask the patient to just flex the knee a little bit before they start doing their hip flexion. Also, it's important to make sure that you're actually isolating the hip joint by putting your testing hand proximal to the knee. I have seen lots of people test hip flexion by putting their testing hand distal to the knee. Just be careful doing that because you're then introducing a confounding factor into your assessment because you're then not isolating the hip joint because you've now got the knee joint involved as well. So someone could have hip flexion weakness, but they could trick you by having a really strong knee extension, for instance. And so they could extend their knee and push up on your hand, and you think that they're pushing up with their hip flexion, but actually it's their knee extension. If someone's obviously strong or based on the position of their knee, you probably can figure out that it is actually coming from the hip. So there are workarounds for that. So it's not the worst thing in the world to do that, but I just think it's an unnecessary way to complicate things for yourself, and it's an unnecessary way to possibly compromise the validity of your examination. So I would recommend using your testing hand proximal to the knee joint. Now, in terms of knee flexion and extension, the main trick here is just being careful with your wording, because if you ask the patient to bend their knee, so often the patient misunderstands what you mean and they don't do anything, or they actually extend their knee rather than flexing their knee. So I sometimes find it more helpful to say, bring your heel in towards your bottom, and that's how I get them to flex their knee. And then when I want them to extend their knee, I then say, now do the opposite. And that tends to be better understood by the patient in my experience. Ankle flexion and extension, I don't have any specific tips for. And then in terms of other muscle groups or joint movements that you may test for, more so I would argue in a specific neuromuscular context, as I mentioned before, is hip abduction and adduction, ankle inversion and eversion, and great toe dorsiflexion. And they're all essential if you're in a neuromuscular clinic or if you think someone has a lumbosacral radiculopathy or plexopathy or peripheral nerve problem or myopathy in the lower limbs. It's important to do these additional muscle groups as well. But if I'm seeing someone with epilepsy or a migraine, I don't routinely test these just to save time. As I said in the previous episode, it's also important that you test the power somewhere in the middle of the joint's range of movement as a general rule of thumb, as opposed to being at the extremity of the range of movement, because that can cause the false impression of weakness. So when you're testing knee flexion, don't test knee flexion when the knee is already completely extended or almost completely flexed, because then it may appear weak. So have the knee partly flexed and then ask them to flex it and then extend it. And that's giving the patient the best chance to actually demonstrate their true power. So I've got the MRC grading on this slide, but I'm not going to go through it again because I went through it in the last episode. So please go over that if you haven't already listened or watched that episode. But just to mention quickly, it's a score between 0 and 5 out of 5. And again, I won't go into this again, but the main trap is using an inappropriate amount of force yourself when testing. And of course, you can't really use your own lower limbs to examine the patient's lower limbs. That would be the weirdest thing ever. So you're going to be using your upper limbs to examine the patient's lower limbs. But of course, the lower limbs are much stronger muscles than the upper limbs. So it's even more true in the lower limbs that you really do need to apply a surprising amount of force, especially for the proximal muscles. And the main mistake that I see people do is using an insufficient amount of force and therefore incorrectly grading the patient's power as being stronger than it really is. So just make sure that you apply sufficient force, and it's probably more than you think that you need, and it's probably more than what you're currently doing. Now, reflexes. What are my tips here? Big tendon hammer. It is really, really, really important, particularly for a obese patient when examining the patella jerk. So if you've got someone with a BMI of 45 and you're trying to strike their patella with a tiny little reflex hammer, you're going to have a bad time. It is so much more helpful to have a nice big juicy tendon hammer with a nice big juicy head to it so that you can get some weight behind it and apply a sufficient strike to elicit a sufficient knee reflex. Now, how do you actually elicit each of the reflexes? So for a patella jerk, I would recommend examining the patella jerk with the knee passively partially flexed at approximately 135 degrees. So you don't want it like flexed at 90 degrees. You just want it flexed a little bit. So it's at about 135 degrees. If you're not winning in eliciting a patella jerk on the bed, then it is a lot easier if you then at the end sit the patient up over the side of the bed, have their legs dangling over the edge of the bed, and then elicit the patella jerk. That way it is easier to do if necessary. Now, in terms of the Achilles jerks, there's two different ways that you can do it. The first way is that you passively dorsiflex the ankle and then directly strike the Achilles tendon. And that's the traditional way that you would examine the Achilles jerk. Everyone also is taught to flex the knee of the leg that you're examining so that the examined ankle is sitting on top of the contralateral shin. Personally, I don't think that really adds much. I think it just adds another step of confusion, and I think it's usually easier just to externally rotate the hip a little bit so that you can actually access the Achilles tendon. The other way that you can elicit this jerk is with the ankle, again, passively dorsiflexed, and instead of striking the Achilles tendon, you actually just strike the plantar surface of the foot. But really, I strike my own hand that is being used to passively dorsiflex the ankle. And that technique has been shown in studies to be equally effective to the first technique, so either technique is completely fine. It's important that the ankle is relaxed. So even though you're passively flexing the ankle, you don't want the patient to be actively flexing the ankle themselves, because that will, in many cases, just obliterate the reflex. So you do need to try and, I sometimes even use the words loosey-goosey, just relax. You let me do the bending. You just pretend you're asleep. You let me do what I need to do. You just, please don't be involved in this process at all. Just chill out, and then you passively dorsiflex the ankle, and then elicit the reflex. Now, in either case, it's also helpful to assess for clonus. And this confused me a bit for a while, because I was taught in medical school to assess clonus when assessing tone. And that's still what I do, just out of habit, and it's reasonable to do that. But if someone has clonus, that's actually indicative of hyperreflexia as opposed to hypertonia. And that's something that I had wrong throughout all of medical school and some of my junior doctor years. And I only realized that in the last probably 4 years or so, that clonus is consistent with hyperreflexia, not with hypertonia, even though, of course, the two can be closely linked and are often seen together. So what's actually normal and what's abnormal when it comes to clonus? So usually 0 beats or 1 or 2 beats of clonus is fine. So that's considered normal. If you've got 5 beats of clonus or more, then that's abnormal. And there have been times when I've examined patients and they literally have sustained clonus, as in truly infinite clonus. You could have your hand there for a minute and you might feel 100 beats or more, and it only stops when you stop examining. It's quite remarkable, actually, when you come across that. The borderline is the borderline. So it's when you're getting 3 to 4 beats of clonus. So that may be abnormal, especially if it's asymmetrical or if it's in combination with other signs. So if you have a patient who's got 0 beats of clonus or 1 beat of clonus in the left, but they've got 3 or 4 beats of clonus on the right, then that definitely could be significant, especially if there are some other upper motor neuron signs in the right lower limb. Now, the plantar reflexes. So how is this done? It's done by scratching the plantar surface of the foot, and you begin in the posterior and lateral aspect of the sole, and then you move anteriorly in the anatomic position, but from your own angle, you're moving up. And then you move anteromedially, making a curved shape. So you're going from the heel up towards near where the 5th digit is, and then across around to near where the 1st digit is. And what you're looking for? So the main thing you're looking for is an upgoing great toe, so the 1st digit. And typically you also get fanning, so abduction of the other toes. And that is known as the extensor response or the Babinski response. I like just to say upgoing. I think it's simpler. And that's consistent with an upper motor neuron lesion. Conversely, a downgoing great toe, which is the term I like to use, but it can also be called a flexor response, is normal. Technically speaking, you're not meant to say a downgoing Babinski, because technically the Babinski response is just the upgoing response, and some people might be a bit frustrated if you say that. I couldn't care less personally, but some people do get a bit funny about that. Now, in terms of what happens if the toe just doesn't move at all, so we call that a mute response. I was always taught that a mute response is normal and not significant, but I have come across some people in texts who have somewhat disagreed with that. So what I would say is that a mute plantar response is normal if it's symmetrical. If it's asymmetrical, so if one plantar is downgoing and the other plantar is mute, then I'd probably still argue that it's still normal, but acknowledging that some people would say that that might not be normal. But it should raise suspicion, basically. So if someone's got a downgoing left plantar and a mute right plantar, I wouldn't personally call that abnormal in and of itself. But if it's in combination with other upper motor neuron signs in the right leg, then it could be abnormal. So it's just enough to raise your suspicion, basically. And basically that's because we don't like asymmetry in neurology. We're very symmetrical people. We like symmetry. Any asymmetry is a bad thing when it comes to neurology. Then in terms of how much force you actually apply, I would recommend, and you probably won't read this anywhere, but I would recommend just beginning with a really gentle scratch because half the time, or more than half the time, that's all that is necessary in order to elicit the plantar response. And it also makes it less likely that the patient will just withdraw by flexing their knee and pulling away from you, and then it becomes uninterpretable. So if you just do like a nice little scratch, that's all you need half the time or more. And then if that's not sufficient to elicit a response one way or the other, then you have to become progressively more vigorous until you've elicited the response. And you can just try and relax the patient's leg, try and encourage them not to withdraw from you, because if they're flexing their knee and pulling away from you, it makes it really difficult to interpret the response. In terms of what equipment to use, I think if you're just doing a really gentle little light scratch to begin with, it's fine just to use the fingernail of your own thumb. Whereas if you need to apply a more vigorous force, then you should use the end tip of your tendon hammer to do so. I would not use your Mercedes key, which is just super gross, even though I acknowledge that historically people have used their fancy car keys and people have written about this, but yuck, don't do that. So this slide goes into the grading of the reflexes. I'm going to skip over part of this because I went over it in the preceding talk on the upper limbs. But just as the very brief summary, my recommendation would be to grade it as hyperreflexic or increased, normal, hyporeflexic or decreased, or areflexic or absent. And I prefer to stay away from the +2, +3, +0, 4+ system because there seems to be a bit of variety or variability in the way that people have been taught and the way that people interpret that. And then in terms of how to actually score it, the main tips to be aware of is that a bit of a wobble under your skin is not actually a reflex, and you need to see the joint actually move. So for a reflex to be truly absent, it needs to not move. The joint needs to not move despite reinforcement. Hyporeflexia requires reinforcement to elicit the reflex. Normal is normal. And then hyperreflexia is a spreading reflex in terms of the joints adjacent to the examined joint contracting, or a stimulus distant to the joint causing contraction of that joint, or pragmatically, and I'll reiterate this just because I think it's a really useful point, which you probably won't read anywhere, is that the force required to actually elicit the reflex and the equipment required to elicit the reflex, I do think is actually a really helpful marker. So normally you need a tendon hammer to elicit a reflex in many instances, or a very vigorous tap with your fingers without using a tendon hammer. But if you can elicit a lower limb jerk just with a very, very gentle tap of your fingers, just a very gentle tap, and that elicits like a really healthy, generous reflex response, that's not normal. And sometimes I've seen patients who are so hyperreflexic that it almost feels like you could sneeze on the joint and it would move, which is using a figure of speech. Of course, you're not going to be sneezing on people's joints and it probably wouldn't do anything, but really it is just doing the lightest little tap with one little finger and it elicits this vigorous movement of the joint. So I think that is a sensitive and a reliable marker of hyperreflexia. One thing which is specific to the lower limbs that I'd like to mention here is you may have heard of cross adductors, so cross adductors. And what that refers to is when you're examining the patellar jerk and you're looking at the hips, and you may see that the contralateral hip, or maybe even both hips, adduct in response to you examining the patellar jerk. Now, this is said to be a reliable marker of hyperreflexia, PER reflexia. There's a few points I would say here, though. Firstly, you should make sure that the hips are sufficiently abducted to begin with so that the skin of the medial thighs are not touching each other in the first place. Because sometimes I've seen people examine a patellar jerk and then the leg moves a bit or the wobble of skin gets transmitted, and you can just see the skin of the medial thigh of the examined leg wobbling and touching the other leg, and both legs wobble a bit, and that can be misinterpreted as a cross-adductor response when actually it's just a transmission of wobbly skin. So make sure that the legs are abducted enough so that they're not touching to begin with. The other thing that I would caution against is I would caution against over-relying on this sign in isolation and over-interpreting this sign. I'd really like to have some literature to back this up, but I don't. This is really just my anecdotal experience. But I honestly don't think it's that uncommon to see cross adductors truly present as an isolated sign in an otherwise completely healthy patient, including young patients who have no other upper motor neuron signs and they don't have a problem with their central nervous system. So yes, cross adductors are something to look for, and yes, they are significant, especially when it's in combination with other symptoms and signs consistent with an upper motor neuron lesion. But in isolation, if the patient has cross adductors and they don't have any other symptoms or any other signs, I would really advise caution and just being aware of not wanting to overinterpret the significance of that sign. And I'm not really aware of there being literature demonstrating that this sign of its own right has robust sensitivity and specificity and positive and negative predictive values and positive and negative likelihood ratios. So just something to be aware of. I have a mind to doing a bit of a case control or cohort study on this to formally assess this in the future, but I haven't done that yet. So, sensation testing. Again, you can test neglect. Technically, that's a test of parietal lobe, in particular, non-dominant parietal function. So it's more of a higher center sign than a component of the anatomy of the lower limbs themselves. But realistically, you're going to be testing sensory neglect when you're testing sensation in the leg. So I've included it here. It needs to be done with the eyes closed, and it's fine just to do it with light touch. Then you're going to be examining the spinothalamic system, so pinprick and or temperature, and you're going to be examining the posterior columns, so vibration sense and or proprioception. The way that you do this is exactly the same as in the upper limb, so I'm not going to go over it again in this episode. Although the only difference is that with proprioception in the lower limbs, again, you need to use fairly small movements of the interphalangeal joint of the great toe. But the movements don't need to be as small as for the distal interphalangeal joint in the digits of the upper limb. So in the finger, you're just doing these tiny, tiny, tiny little movements. But when you're moving the great toe, which I'll demonstrate with my thumb here, you can do bigger movements because it's normal. In a normal patient, the proprioceptive ability in the fingers is much greater than in the toes. Then 2-point discrimination, I don't routinely do this, but it can be useful if you're evaluating for, say, diabetic neuropathy. And light touch itself, again, I'm not a big fan of light touch. I don't think it really helps discriminate between the spinothalamic and posterior column systems as much as the other modalities that I've already mentioned do. So I normally just stick to them. In terms of how to go about testing, I'll skip over this because it's a bit repetitive to the last episode, but technically you should be testing each dermatome and keeping mind of the plexus anatomy and the peripheral nerve anatomy. Although, again, depending on the clinical context, I don't think it's unreasonable to cut a corner and just do a basic screen of distal sensation if, for instance, you're seeing an epilepsy patient or a migraine patient. But if there's any concern whatsoever of pathology affecting sensation in the lower limbs, then you need to do a proper assessment proximally and distally with a dermatonal approach. Also, do not overinterpret minor asymmetries. If someone has a 5% difference between one leg and the other, who cares? That's not significant. You're going to run yourself up a wall and confuse yourself and get muddled and fall for red herrings left, right, and center if you start putting any diagnostic weight on a 5% difference, which is subjectively reported by a patient. You care about significant, definite differences in sensation between the left and the right or between proximal and distal. So I would frame the question as, were both thighs fairly similar? Were they more or less the same? Or was there a significant difference between the two? And if the patient says, yeah, they were pretty much the same, then that's good enough for me. Whereas if they say, oh no, this left side was definitely less than the other side, or oh no, I could barely feel it at all in the foot, but I felt it really well in the hip, that is significant, and that is what you should put diagnostic weight on. And then finally, do you need to test pinprick and temperature? And do you need to test vibration and proprioception? For a general neurologic screening examination, not specifically in the neuromuscular context, I think this is low yield and it's okay just to do one from each of the two groups. And I like to do temperature and vibration sense, both just using my cold metallic tuning fork because it's nice and quick. But if you are really actually concerned based on the previous examination signs or based on the history of a condition affecting sensation in the lower limbs, especially if you're seeing the patient in a neuromuscular clinic, then yes, you do need to test all four modalities. And the reason for that is it is not uncommon that someone will have normal pinprick but abnormal temperature and vice versa, or that they might have normal vibration but abnormal proprioception, or vice versa. So you're increasing the sensitivity of your assessment by testing all four modalities, even though it is more time consuming. So, how do you assess coordination in the lower limbs? The main way is through the heel shin test. So I ask the patient to accurately run the heel up and down the middle of the contralateral shin, up and down from the knee to the ankle. And I tell the patient that they're getting points for accuracy. So I really want to see it be accurate. It's not a race. They don't have to be super fast up and down and be all over the place and inaccurate. I just want to see an accurate movement up and down the shin. A lot of people do this thing where they ask the patient to roll it down the shin and then to elevate the leg up into the air on the way back up and then place it back on the shin to go down again. I don't personally think that adds much, and it can add a bit to confusion. I usually just ask the patient to accurately roll the heel up and down the shin. One other tip I will say here is if the patient is wearing clothes, especially if they're loose clothes that are covering the distal part of the lower limb, then it's really important that you pull those loose clothes up, because if they're wearing baggy pants, the friction of the heel running up and down the contralateral shin can get in the way, and it can make a heel shin test look ataxic when the problem is just the baggy pants that the patient was wearing. So don't do that. So if they're wearing like tight jeans or something and you haven't really exposed the patient and you're doing a quick screen, then it's probably not a big issue in terms of the heel shin testing. But if they're wearing baggy pants, make sure you pull them up proximal to the knee joint so that it's skin on skin when you're doing this part of the assessment. Now, how else can you assess coordination? So you can assess foot tapping. This is trickier though than assessing for dysdiadochokinesis in the upper limbs, because it's trickier to distinguish normal from abnormal foot tapping, because in reality, I find that a lot of confused patients and a lot of elderly patients, they seem to really, really struggle with foot tapping despite not actually having lower limb ataxia. So what are you looking for? You're really just looking for an obvious asymmetry in the rhythm, the consistency, the coordination with the foot tapping between left and right. That can then be a problem if someone actually has a bilateral cerebellar syndrome and they have bilateral foot tapping ataxia. It can be difficult to distinguish normal from abnormal, and you just need to apply a judgment in that instance on a case-by-case basis. One other thing that can be done is toe finger testing. So this is the equivalent of dysmetria finger nose testing. You can do toe finger testing. So you get the patient to, with their great toe, reach the target, which is your finger, and go back and forth. This can be done, and I have seen some people do this, although pragmatically it's much more difficult than doing finger nose testing in the upper limb, given that the hip has far less fine motor control than the shoulder joint does, and any articular problems affecting the hip or the knee or the ankle can affect this test. Any weakness, or even if the patient just has increased body habitus and they're fighting against a lot of adipose tissue in lifting and coordinating and moving their lower limb again around against gravity, can really interfere with this test, with this toe finger test. Whereas in the upper limb, you're mainly moving with gravity eliminated because you're moving left and right. Whereas when doing toe finger testing, you're moving up and down predominantly. So I don't really like the toe finger test. It's not super helpful most of the time. So I would have a preference for heel shin testing and, if needed, foot tapping testing. But it is an option. It is there. So if you want to do toe finger testing, it is available to you. Now, coming to the end is the assessment of gait and stance. So firstly, you're assessing standard gait. So you're looking at the base width. Is it broad-based, narrow-based, sometimes intermediate-based if you're not completely sure and you want to hedge your bets? You're looking at the cadence of the walking, the symmetry, you're looking at foot strike, etc. And then there are a number of additional considerations in an extrapyramidal context, but of course you're going to take note of these if you see them. So is there any festination? Is there any turning on block? which means turning in numbers. So they get to where they want to go, and then you ask them to turn around, and instead of turning around in one quick movement or one or two movements, they do these little incremental movements in 5 degrees or so, and it might take them 5 or 10 or 15 little steps just to turn through 180 degrees. You're looking for reduced arm swing, especially if it's asymmetric. You're looking for astute posture. Sometimes you do abnormal retropulsion testing. Look out for a magnetic gait in the context of normal pressure hydrocephalus. So those things are mainly for an extrapyramidal or a neurodegenerative context. You don't have to routinely do all those things just in a standard neurologic assessment if you're really not thinking about those conditions. But if you see them, you're obviously going to make comment on them, so you don't just ignore them if you see them. Then you do some special tests. So you do tiptoe tests, and that's testing for any posterior compartment weakness. So if the patient is unable to plantar flex their ankles, then they're not going to be able to walk on their tippy toes. Then you're testing the heels. So that's testing more for a foot drop or for anterior compartment weakness. So if the patient can't dorsiflex their ankle, then they're not going to be able to walk on their heels. And then you're testing tandem gait, and that's really testing for a cerebellar ataxia. So if someone's ataxic, they're not going to be able to walk in tandem. So that's heel-toe walking. Then you're going to be doing a Romberg's test as well. And really, you probably would do this before you walk them, not afterwards. So to do this, you get their ankles touching each other. You have both arms outstretched and supinated, and you ask the patient to close their eyes. Sometimes it can be a little bit tricky to interpret, but I would say that no sway is obviously normal. And if there's the tiniest amount of sway that you have to second guess yourself as to whether they even swayed or not with completely maintained posture and they don't fall, then I call that normal as well. Conversely, if there's a marked degree of sway, especially if it's to the extent that they look like they're about to fall, or if you need to then put your hands on the patient to stop them from falling over to maintain posture and not fall, then that's clearly an abnormal response. And one trick here is you don't want the patient to be leaning up against a wall or to have the posterior aspects of their lower limbs or their buttocks pressed up against a bed, because that then provides a sensory input and it therefore completely negates the validity of the test. So you need to make sure that the patient is just in the middle of the room, not pressed up against anything when you're doing this test. There is also this modified Romberg's test where rather than getting the patient to stand with their ankles touching each other, you get them to stand with their feet at a comfortable degree of separation if they're unable to stand with their ankles touching, and then you proceed with the test. So that's something that you can do if the patient really can't stand with their ankles touching each other, but if they can, then you should just do the normal version of Romberg's test. So what are we doing when we're assessing someone's stance and gait, taking a step back? What are we ultimately trying to achieve? So we're trying to put the gait in a particular pattern, which then fits with various diagnostic categories. So is it a hemiplegic gait with, say, hip hitching and circumduction? Is it a paraparetic gait with, for instance, scissoring? Is it a myopathic waddling gait? Is it an ataxic broad-based gait? Is it an antalgic gait because of a musculoskeletal problem with a limp? And one other thing to be mindful of is the so-called sensory ataxia. So that's when someone appears to have an ataxic gait, but rather than being owing to a cerebellar problem, it's owing to a sensory problem where the patient isn't getting sensory feedback really in terms of proprioception, maybe in terms of normal tactile sensation on the plantar surface of the feet. So they're not getting that feedback when their foot has actually touched the ground. And you can imagine how awkward it would feel if you were trying to walk on the ground and you didn't actually know when each foot had actually struck the ground. So that patient can then have quite aggressive foot slapping, and you might hear the feet slapping on the ground, and they might look broad-based and they might look ataxic and unbalanced, but it's actually not owing to cerebellar pathology, it's owing to the lack of sensory feedback. So that's what people mean when they refer to a sensory ataxia. And you can try and distinguish a sensory ataxia from a cerebellar ataxia based on some of those features I just described, but also based on the other components of the neurologic examination that I've just been through, specifically the sensory testing and the cerebellar testing. So this is the last slide. It's probably the least important slide in the talk, but I'd just like to say I personally do everything that I just described in a slightly different order because it's faster and more efficient. I would recommend that you do not do this if you're being examined in an examination setting, because your examiner will freak out and think you've forgotten something and messed it up, and you'll get them in a bad mind state, and that's not going to be good for the mark that you receive. But in terms of your day-to-day examinations, if you do want to speed things up a bit, you could consider mixing the order up a little bit in order to do so, but it's absolutely not necessary and you don't need to do this. But the faster order that I like to do it in is I examine gait and stance at the beginning, because the patient's going to have to stand and walk towards the examination bed anyway, and it gives a nice initial overview. I do inspection, and then, if necessary, palpation. I then do tone and power. I then go into coordination, because we're still in the motor system and I'm still not using any equipment yet. I then go on to sensation, because this requires equipment, and if I'm just doing a screen, I choose to examine temperature and vibration sense most of the time with my trusty tuning fork, which is metallic and nice and cold. So 2 birds with 1 stone there. And then I do reflexes at the end, which requires the equipment, and mainly because I then finish up with the plantar responses, which are the only component really of the entire examination, which can be a bit uncomfortable for the patient. So I like just to leave that for the end, so that I've got the patient on side with me for the whole examination. And then if I do cause a bit of pain and make them a little bit unhappy, it's right at the end of the assessment and not at the beginning of the assessment. But if you're doing your plantar responses well and appropriately, it really shouldn't be too painful or uncomfortable for the patient. So that's all I had to say for today. Thank you so much for tuning in and for listening and watching. Please like, comment, and subscribe if you found this helpful. Visit our website, which is rneurologyeducation.org, R with the letter R, for all of our media formats and additional content. Find our videos on YouTube and our audio podcasts wherever you listen to your podcasts, and join us on social media, all at the same domain, rneurologyeducation. And email us if you'd like at contact@rneurologyeducation.org for any questions or to subscribe. From cortex to curiosity, this has been Risfeld Neurology Education. Until next time, keep calm and synapse on.